Life's this game of inches. So is football. Because in either game, life or football, the margin for error is so small. I mean, one half a step too late or too early, and you don't quite make it. 1/2 second too slow, too fast, you don't quite catch it. The inches we need are everywhere around us. Hell yeah. They're in every break of the game, every minute, every second. On this team, we fight for that inch. On this team, we tear ourselves and everyone else around us to pieces for that inch. We claw with our fingernails for that inch. Because we know when we add up all those inches, that's gonna make the difference between winning and losing. Between living and dying. I'll tell you this, in any fight, it's the guy who's willing to die who's gonna win that inch. And I know if I'm gonna have any life anymore, it's because I'm still willing to fight and die for that inch. Because that's what living is. The 6 inches in front of your face. Now, I can't make you do it. You gotta look at the guy next to you. Look into his eyes. Now, I think you're gonna see a guy who will go that inch with you. Hell yeah. You're gonna see a guy who will sacrifice himself for this team because he knows when it comes down to it, you're gonna do the same for him. That's a team, gentlemen. And either we heal now as a team, or we will die as individuals. That's football, guys. That's all it is. Now, what are you gonna do?
So I'm Dave Barounis. I'm going to be talking about sepsis today. I have no disclosures, but I also have no magic bullets for sepsis. I think the most important thing is that what we tried to show in that first little tidbit is that sepsis is really a game of inches. It's the adding up of these things that we do that make the difference in whether our patients live or die. And so what these small changes that we can make at the bedside are what are going to make the difference for us. This is a large multidisciplinary crowd of pharmacists, nurses, PCAs, residents, physicians, emergency room physicians, critical care doctors, hospitalists, people from all, and if I missed you, I'm sorry, but people from all over that are interested in taking care of critical care patients. And the coordination that we do together is what decides whether our patients are going to walk out of the hospital alive or not. It's not going to be one magic drug that's created. So I'm going to give you 4 small things that I think you can change. I would have done 5, but I got 20 minutes, so we had to cut out one. So I'm going to give you 4 small things that you can make in your life, changes that you can make today. And if you're already doing these things, that's great, but these are things that I think we can do to affect the outcomes of our patients. So the first thing I want to talk about is intravenous fluids. How many people here think about the fluid that they use when they give it to a patient with sepsis? Raise your hand. Whether you think about lactated ringer, normal saline, sodium bicarb, plasmolite if you got it, which I know if you're an advocate or you don't, but Normasol if you're in the operating room, albumin. So these are the things that sometimes come to the mind of us of like, what fluid should we be using? And I'm going to argue to you today that one fluid choice is better than another, if you don't already know that. And that the way to try to resuscitate our patients is to stock the shelves with the fluid that's best for our patients, so that when you need that 500 cc bolus right away that you're going to give, you walk to the shelf and the fluid choice that's going to improve our patient's outcome is already available, rather than just give whatever's immediately available, which is what happens to all of us most of the time. So Matthew Semler was out of Vanderbilt University, did a study called the SMART trial. This is balanced crystalloids, which was plasmolite or normal saline, lactated ringer. 95% of the time, it was lactated ringer. So you can take this and apply it to our patients versus normal saline. And what they did was they looked at hard clinical outcomes. This is called the MAKE 30 outcome. They combined 3 things: persistent renal dysfunction, which means the patient was on dialysis when they left the hospital, continuous renal replacement therapy, and mortality. And if you see on the right, we have saline, and on the left, we have lactated ringer. And if you look at the difference in the outcomes, they're almost all driven by the deep purple, which is mortality. So there was a greater than 1% increase in mortality for patients that were critically ill patients admitted to the ICU who received normal saline. I'm going to repeat that. There was a greater than 1% increased risk of mortality for patients admitted to the ICU that received normal saline over lactated ringers. Surgeons in the group, you know that in that surgical ICU, patients received lactated ringers. But in the medical ICU and medical doctors for years, we had been using normal saline. And I hate to say it, but I think that the surgeons had gotten it right. But a well-meaning consultant always comes in and says, what about hyperkalemia? The patient's got a potassium that's elevated. You can't use lactated ringer. It comes up over and over again. And the issue is that actually the pH on the outside of a normal saline bag is about 5.6. In addition, where is all the potassium in the body stored? It's all intracellular. So every single study that looks at normal saline demonstrates that the serum bicarbonate drops when you give normal saline to a patient, okay? And so what happens is the H plus ions develop outside of the cell, and there's an H plus K plus exchanger. And I already said that all the potassium is stored inside the cell. Potassium starts to come out, and over again, we see when giving an acid to a patient, the serum potassium goes up. You've seen this many times. The patient's about to start on CRRT, the pH is 6.9, there's acute kidney injury, and the potassium 7. As you improve the pH, the patient starts to have their potassium start to come down. Happens in DKA every day. By 6 hours into DKA treatment, you're supplementing the potassium, mostly because you fixed a severe acidosis and they're actually hypokalemic overall from a total body perspective because the potassium is just shifted outside of the cell. That sounds great in theory, but Dave, give me some data so I can take it back to practice. So when somebody comes to me and says that, what do I have to go to them with? So again, this is Dr. Semler's paper, 13,000 ICU patients. And the indication for renal replacement therapy is included here. This is in the supplement, so it's not in the paper, this is in the supplement. 11% of the time, they needed renal replacement therapy for hyperkalemia with lactated ringers, compared to 12.3% of the time with normal saline. That number's not statistically significant, but I think it gives you the credence to be able to go back to the consultant and say, you know, there's not really been much difference between these two. It's definitely not causing more hyperkalemia that results in us needing to place the patient on renal replacement therapy. And that's in a large randomized controlled trial. So if you like Seinfeld like I do, you know, the soup Nazi says, hyperkalemia, no normal saline for you. Come back in 1 year. So the next thing is fluids or drugs. How many people here think of fluids as a drug? When you dose heparin, you think about the patient's weight. You think about whether you're treating a PE or acute coronary syndrome. When you dose antibiotics, you think about their renal function. How do we dose fluids? We dose fluids based on the Step 1 guidelines tell us 30 cc's per kilo for every patient that comes to the hospital with sepsis. And so I think we're not too scientific about how we give fluids to patients. There was an attending that I had when I was in fellowship that used to say, patients may well have as many medical problems as they damn well please. And what he meant by that was you could have ESRD, you could be hypertensive, diastolic heart failure, and those patients are not the same as a 23-year-old septic pyelonephritis. Those are very different patients and how they're going to respond. In addition, the source of sepsis, a pneumonia versus an intra-abdominal source of sepsis, is very different overall. You know that a pneumonia patient is more likely to develop respiratory failure as they develop fluid overload and extravascular lung water, compared to a septic patient with an intra-abdominal source where they're just third spacing all their fluid in their abdomen. We've all seen this. So this is Thomas Latta in 1832. He was the physician that invented normal saline during the cholera epidemic. He noticed that patients were having 5 to 6 liters of diarrhea a day. They would become this bluish hue before they died. And he hypothesized that there was this fluid that was being lost from the body that needed to be repleted. So he created this compound that he eventually called saline. And he wrote about the first patient that he gave this compound to. I'm going to read his excerpt from the Lancet in 1832. In this, having no precedent to direct me, I proceeded with much caution. The first subject of the experiment was an aged female. She had apparently reached the last moments of her earthly existence, and now nothing could injure her. Indeed, so entirely she was reduced that I feared I should be unable to get my apparatus ready ere she expire. Having inserted a tube into the bacillic vein, cautiously, anxiously, I watched the effects. Ounce after ounce was injected, but no visible change produced. Still persevering, she began to breathe less laboriously, and soon the sharpened features and sunken eye and fallen jaw, pale and cold, bearing the manifest impress of death's signet, began to glow with reanimation. The pulse, which had long ceased, returned to the wrist. Thomas Latta knew back in 1832 that the amount of fluid that patients needed was unknown, that he had to slowly titrate the amount of volume that came into the patient. It wasn't the patient's hypotensive reflexively order a bolus of fluid. It wasn't that the patient's urine output was low, so the answer was always giving another fluid bolus. Carefully titrating and deciding what is volume responsiveness, what is the goal that you're trying to achieve by giving patients fluid. And in addition, a lot of patients that come to the hospital that are in a nursing home have sepsis for one day. These are patients that are having 5 to 6 liters of diarrhea daily for 7 to 8 days. Think about the volume loss in that time period compared to somebody from a nursing home with 1 day of a fever and a pneumonia. That's the difference that we're seeing between these patients. So let me give you an example. This is a 45-year-old male, status post an orthotopic kidney transplant in 2015. He presented to his nephrologist's office because he had a fever at home. He was on immunosuppression, and he was developing a cough. So his nephrologist sent him to the emergency department to be evaluated for the symptoms that he was having. In the emergency department, patient was febrile, tachycardic, had a normal blood pressure, was not tachypnic, and was not hypoxemic, was 98% on room air, speaking in full sentences. These are the labs. Labs look relatively normal other than the creatinine, baseline 1.1 after the transplant, now up to 2.05. So, and the lactate was 0.9. So the patient has sepsis. The patient is infected. And in order to treat the patient was given 30 cc's per kilo of IV fluid. According to our SEP 1 guidelines, that's what the standard of care would be. The patient was quite hypertensive when they came in. End-stage renal disease was due to hypertension. Echocardiogram demonstrated severe diastolic heart failure. And so the patient received 30 cc's per kilo of IV fluid. If you notice, when they were admitted, they had a respiratory rate of 18, and they were satting 98% on room air. After the 30 cc's per kilo was finished, at round 3, the patient was now breathing 24, satting 94% on 4 liters nasal cannula. A well-intentioned hospitalist on the floor thought, when in discussion with the nephrologist, the patient was dry as the cause of the acute kidney injury, so 150 cc's of normal saline were started per hour for that patient. And then after several hours, the patients are being admitted to the hospital, there's a rapid response called. That's because the patient's tachypnic to 30, satting 95% on a non-rebreather mask. The patient's placed on non-invasive ventilation, doesn't improve. They try IV diuretics, but because of the acute kidney injury, patient's not making any urine. Patient gets intubated, ends up paralyzed and prone on mechanical ventilation. Dialysis is started on the patient, and the patient has a long hospital stay, eventually recovers and is discharged, but has a protracted length of stay due to mechanical ventilation and severe neuromuscular weakness. So the question I have is, the patient was admitted at 9 o'clock on no oxygen, breathing comfortably, and after a total of 6 liters of fluid by the end of the day, when they came in with a bad pneumonia, is intubated, paralyzed, and prone. So the only therapies they've received is Zosyn, acetaminophen, heparin, and fluids. And so I think overall we can look at this as a patient who developed a significant amount of extravascular lung water from the volume resuscitation that was given. So we need to be cautious and think about how much fluid we need to give these patients. This is the triad that you see in the intensive care unit. This is from Dr. Farkas's website, Palm Care, which I think is fantastic. If you haven't looked at it, I highly recommend it. And this is the triad of fluid therapy that happens. The patient's hypotensive or borderline, the urine output's low. Call goes to the resident. The resident sees, no offense to the residents. Call goes to the resident. Resident says, I gave 500 cc's of fluid earlier. That seemed to work. Give another 500 cc's of fluid. You get a transient improvement in the blood pressure because you get improvement in the volume space, and then that starts to extrapolate and extravasate out of the capillaries, results in edema of the myocardium, of the kidney, of the lung. And then all of a sudden, the patient's now hypotensive again. And then we say, well, last time we gave 500 cc's of fluid, it's this positive recall bias of we just did that, it worked, we should do that again. So then we give another 500 cc bolus, and we continue this process over and over again. And this is the vicious cycle of repeated fluid boluses for fluid responsiveness. It happens over and over again. And many studies demonstrate that a positive fluid balance, irrespective of the SOFA scores, age, and other medical problems, is an independent predictor of mortality for patients in the ICU. So how do I decide? What do I do? I think you've got to ask yourself, what are you trying to achieve? If you're just trying to achieve more urine, like patient's going to have more urine output, we need to think about why the patients get acute kidney injury with sepsis. If you look at the kidney in sepsis, there's increased blood flow to the kidney itself. So the kidney has increased blood flow. It's like when you feel the pulse of a really septic patient, it's bounding. They're vasodilated. Giving more fluids isn't going to increase the flow more to the kidney. The damage to the kidney is done at the glomerular level and at the capillary level, but not at the large vessel levels. So giving more fluid isn't necessarily always the answer unless that patient is truly hypovolemic. So the answer of, I got to make more urine, giving more fluid isn't always the right answer. And also this process of, with this vasopressor concern that we have this bias against putting patients on pressors. Why? Because we have bed availabilities that are problems. It's hard to get somebody to the ICU. So we don't want patients on pressors. So we want to give fluids so we don't have to put them on a vasopressor, because otherwise they automatically need an ICU bed, and then Samir's going to tell you need a central line, and somebody else is going to tell you need an A line, and all of a sudden this pipe way that you don't want to go down, so you give more fluids. But sepsis is a vasodilated state, and sometimes being on low-dose norepinephrine is what that patient needs. And if that was your family member, that's the thing that you would want to do. You would want to do what is the most appropriate for them. And so there are patients who need to be on Levophed for a period of time while they're septic. And sepsis is not a one-size-fits-all. The onset of sepsis is different for each patient. When the patient starts getting septic is different. If they started 5 days ago with a pneumonia versus 12 hours ago with the nursing home, they took a temperature and noticed they were febrile and tachypnic, those patients have very different amount of dehydration. So the volume that you're going to need to give them is not the same. But we treat them as if they're the same right now. And again, that's because the guidelines that are telling us that this is what we have to do, we get dinged when we don't do it. And so I think as providers, we need to look at it and say, is that really the right thing, that everyone is created equal? That's exactly how much fluid we need to give? Or do we need to be more precise, which I think Dr. Salinas and Dr. Tyler are going to get to us in the next talk. Next is lactate clearance. I love lactate. Lactate is a great prognostic sign. It lets you clue in to somebody who's sick, more sicker than you might even know when you start seeing the lactates elevated. And its clearance has a positive prognostic sign. What else has a positive prognostic sign is the white blood cell count trending down. So if the white blood cell count 30,000 comes down to 18,000, that's positively prognostic. The patient's likely going to do better. But would you give fluids to resuscitate a white blood cell count? Probably not. And we do that. Think about it right now. If a patient has an elevated lactate, what's the first thing that comes to your mind? How much more volume should we give them? So I think we need to think more about what lactate is. What is lactate? Lactate is our body, stimulating beta receptors with epinephrine. It's our body saying we need to produce more energy, because whatever energy is being consumed in the septic state, is the patient have a cardiomyopathy? How many times have you seen somebody actually has cardiogenic shock? They have an elevated lactate, and the first step is fluid therapy. They get intubated, and then we're diuresing them within 4 hours the last time they got 2 liters of fluid. So we need to think about why that lactate is elevated, not just reflexively order fluids as part of the therapy for it. This was a study that looked at the effect of resuscitation strategies on lactate clearance compared to peripheral perfusion. So what they did was they looked at a capillary refill time in a patient versus a lactate clearance. Oh, no. And basically what they did was hold the microscope over the finger for 10 seconds, clear it, then take it off and look at how long it took for the capillary to refill. So it can be standardized across different providers, nurses, physicians, and look at this. And what they found in this Andromeda shock trial, because they didn't have lactate available in South America where they were doing a lot of these studies, and what they found was that actually if you did lactate, if you followed lactate clearance and resuscitated based on a lactate clearance, there was an increased risk of mortality compared to using peripheral perfusion. And most of the patients who had the increased mortality were patients with low SOFA scores, meaning they weren't that sick. And it's because of the harms of the fluids in those patients. So the less sick your patient is, the more volume that you give them, the patient may have more problems down the line. Lower lactates, low SOFA scores, decreased lactate deltas over 10%. These are the people that had a statistically significant reduction in mortality when they used capillary refill time compared to using lactate clearance. So I'm not saying that you shouldn't follow lactate, but it doesn't need to be an order that's every 2 hours and an ABG every 2 hours till the end of time. I mean, we waste a lot of resources in doing that and following those lactates. The patient looks like $1 million. If the patient got better with the therapy you gave and the lactate is still elevated, what are you going to do with that information? And if the lactate went from 4 to 5 and you've already found the source, the patient's going to the operating room for something, what is it? Is the next therapy really fluids? Is that lactate what's going to tell you that you need to give more fluids? And what I'm trying to argue to is maybe not. The last thing is vitamins. And if you know me and in the ICU, you know I like my vitamins. Not for myself, though, but just for the patients. But I should take more. But so basically what I'm trying to get at here is that a lot of our patients, despite multiple medical problems, obesity, they are actually vitamin deficient. And so the question that we have is there possibly a way to add the vitamins in to treat sepsis? A lot of people say this is hocus pocus. So there's going to be a lot of skeptics about that, and reasonably so, mostly because the data that's currently available is before-after studies or randomized control trials in burn patients, which may not appropriately be attributed to medical ICU patients or surgical ICU patients. So that's where people get a little bit concerned. But this was the study by Paul Merrick before-after trial. They used the Apache database just like we do, and they had predicted mortality in black, actual mortality in gray. And what you find is that when you treat patients with the ascorbic acid, vitamin C, 1.5 grams Q6 hours, thiamine, and hydrocortisone, there was a significant reduction in mortality across the Eastern Virginia Medical School where they did this. They had an independent data monitoring service come in, now up to 350 patients from the original 180 published in CHEST, and they still had the same outcomes. So they've had a drastic reduction overall in mortality in their patients. We're all hoping for that randomized controlled trial as soon as it comes out to give us more information about this. But Eastern Virginia looks very similar to a hospital similar to this in terms of their patient population and their Apache scores and their illness. So the other thing that's come out is the Fowler study that hasn't been published yet, but he presented the data already. So I cut out his slides so that you could see some of the data that he had. And so this is the Citrus ALI study, and our friends from St. Luke's Roosevelt up in Milwaukee may already know about this study, so maybe they can give us some insight to what they felt about this. But 170 patients were enrolled. They were septic patients with acute lung injury. And so what they did was they did a randomized trial of patients getting vitamin C versus no vitamin C with sepsis and acute lung injury. And what they found was there was more ICU free days, which if you're a patient, you care about. If you're a hospital, you care about. And so I think that's a win for both teams. More ventilator-free days, and improvement in mortality. And if you look at the mortality from patients receiving vitamin C, you notice that in the gray is where they receive the vitamin C. There's a significant drop-off in the placebo early, and in the vitamin C group, you notice that it kind of stays up. And then once they discontinue the vitamin C, there's a small catch-up. So there's a question of maybe do they need a more prolonged course of vitamin C? Vitamin C is not made by primates, so other animals actually make their own vitamin C. We have to actually eat it, and you can only absorb so much oral vitamin C. So that's why it has to be given intravenously, because we saturate our receptors in our gut. So the next thing is thiamine briefly. Thiamine, this is Mike Danino that did this, so that in thiamine deficient patients, which you're not going to know when they walk into the hospital, 28 out of 116 patients were thiamine deficient in septic shock, and there was a significant reduction in mortality in the patients that received thiamine. Thiamine is dirt cheap, has almost no side effects. If this was a drug from a company, you would be spending tons of money to try to use thiamine and vitamin C. And someone may brand a group of drugs, steroids, thiamine, and ascorbic acid to try to sell it to us, but it's cheap as it is now. These are things that we can use. Now, we do have a shortage, so that is an issue that is going on. But again, when you're at the bedside, you have to I try to think about the person in front of me. They're like they're my family member. So I do whatever I think for that patient needs. And steroids, I think, is the last piece of this. It goes back and forth all the time. But the adrenal study just recently was published last year, and it demonstrated that there was no change in mortality, but there was a reduction in ICU ventilator days, a reduction in the ICU length of stay, a reduced amount of time that patients spent on vasopressors. So these are endpoints that patients care about. So I think that this combination is the thing that we're going to need to continue to look at. And lastly, this is the traditional approach to sepsis. We give antibiotics, we give a lot of fluids, and when they're finally fluid resistant after 6 hours, we give them norepinephrine. When they get to 20, we add vaso, and then we add epi if they've got this problem, and then we add stress dose steroids. So we have this kind of like stepwise process in how we treat patients. And my argument to us is that we need a regressive early escalation treatment strategy with aggressive deresuscitation later. Hit them early and hit them hard. With some fluids, not as much as we were before, IV antibiotics, metabolic resuscitation with steroids, ascorbic acid, and thiamine. Use norepinephrine early. There's a study ongoing about this right now. And then look at the patients and make your decisions based on that. So like Al Pacino said, the inches that we need are everywhere around us. They're in every break of the game, every minute, every second. Thank you guys very much. I really appreciate everybody coming.